So our next speaker is Sabrina Sacconi from the University of Côte d'Azur in Nice, France, on reassessing clinical phenotypes in facioscapulohumeral muscular dystrophy, late-onset FSHD presentations.
So I stand in from you and the coffee. I will try to be as fast as possible. These are my disclosure. So as the previous speaker and other speaker have underlined, not all the FSHD are created equal. And understand that the variability of clinical phenotype, it's very important because patients, they can have different clinical journey, different clinical evolution, and this can change many things in the way that we assess the patient, the response in clinical trial, the way that we will see if you have a drug in how we can assess patient in real life. So I decided to have the angle, which is one of the easiest one, to try to stratify patient by the age of onset. I will not speak about very severe affected patient because as we heard, unfortunately, these patients are not yet in clinical trial. And I will not speak also of a patient that has no symptoms, like the woman we see on the right of the screen. But I will try to concentrate on population that are actually included in clinical trial, that is a population that is classified by some score, clinical severity score, and that is not always homogeneous. Among this population, we can find patients with a very classical clinical phenotype and other patients that may be not so classical. If you see a lot of FSHD patients, you have in mind this presentation that it's more lower leg and axial that you can see in older patients. And the older FSHD patients are not so rare because we are all aware that the population is aging in Europe as well as in US, and the aging of the population gives to an increase in all diseases and also in genetic diseases that are not lethal, with an increase, a very important increase in muscular dystrophy, and especially in FSHD cases. These are data that come from our French national database that included 1,300 and something patients. And when we look at the distribution of the age of onset, we see that there is a lot of patients that have later onset of the disease compared to what was described before in literature. We see also, if you look at the age of the molecular diagnosis, this is also shifted, and we have this type of distribution. So this study wanted to see if this late onset FSHD patient that have been described in the past as having a milder phenotype with lower frequency of facial involvement and lower disease evolution are really like they are described. And for this reason, to conduct this study, we look into the data of the RESOLVE study that was described before by a previous speaker. I wanted to remind you that this study is only included patients that are ambulant and patients that are symptomatic. So it's not a full natural history. Of course, we're going to have late onset patients asymptomatic, but we are talking about patients that are going into a clinical trial. And here we defined late onset as patient that has in age at onset superior or equal to 45 years. These are all the sites that included in the RESOLVE study. So we had a total population of 231 FSHD patients. with a slight prevalence of male, all of them ambulatory, 65% able to walk independently, at 35% needing assistance to walk. The repeat distribution was 5.8 plus minus 1.8, and the age, the mean age was 50 years old. The mean diagnostic delay was 10 years, and the disease duration was 25 years, and the mean clinical severity score was 5.42. Of course, we can see a statistical significant difference in age at onset in the two groups, and we can see that the patient that has an age at onset superior to 45 are older, but this is normal, otherwise they will be dead. And we can see that this population in this cohort represented the 20% of the cohort. And in this cohort, we have a slight prevalence of female compared to the cohort with the earlier onset, in which we have a slight prevalence of men. In terms of disease duration and disease distribution, there is a diagnostic delay. There is a statistical significant difference because we can see that patient that has age at onset inferior less than 45 have a longer disease duration. And also this can be something due to the fact that, of course, we not include the patient 90 years old. And then we have the diagnostic delay that is significantly lower in the late onset population. Why? Because this patient probably are diagnosed when they become symptomatic, so it's very difficult to establish the real age at onset of the disease. When we look at the first symptom that is reported by the patient, we found the things that is reported in literature, that this patient has a lower frequency of facial involvement as a first reported symptom, but surprisingly, we find that this population has a higher frequency of lower limb involvement and lower frequency of upper limb involvement compared to the earlier onset. When we look at the functional involvement of the facial, we see that the fact that is not only the first reported symptom, but also during the disease, the later onset population tend not to have facial, less frequent facial involvement. When we look at the proximal upper extremity involvement, we see that the late onset population have a milder functional proximal involvement compared to the earlier onset. When we look at the time up and go, which is a functional test that reflects part of the axial involvement and the lower limb involvement, we have a statistically significant difference between the two populations, being the later onset, the one that do the test more time, but I'm not sure that this is a clinically significant difference. But when we look at the need of assistance, we clearly see that later onset patients have a significantly higher need of assisted device. And when we look at the 6-minute walking test, we see that there is a statistically significant and also clinically meaningful difference between the two populations, because there is more than 30 meters of difference between the two cohorts, being the later onset the most affected. So this is the clinical severity score distribution. And we see that this is the overall distribution of the patient with earlier onset and later onset, and we see that the later onset are in the higher part of the scale, being more severe, but this scale is a scale that is supposed to be applied to patient that has a classical phenotype progressing from facial to upper limb to lower limb involvement. So we don't know if it's the best way to quantify the clinical severity score in this patient that are more affected in lower limb. We have also to say that this patient anyway have a higher frequency of use of assisted device, so they are not milder as we thought before. And these are, if we divide the patient and with a clinical severity score inferior to 4 or superior or equal to 4, we see the same things. So in conclusion, in patient with the later onset that we have defined as having age at onset superior or equal to 45, we have, as expected, a lower frequency of facial involvement, but we have surprisingly less upper limb involvement and more axial and lower limb involvement, and higher percentage of patients using assisted device, meaning that this population, which is an ambulant population that can be in clinical trial, is not so mild. And maybe we'll need a different way to assess disease evolution as the class compared to the classical phenotype, and or to assess the therapeutic response in real life, and also may have a different therapeutic response itself. So, of course, prospective data are needed to support this hypothesis and also to look at the evolution of these two different cohorts during time. I would like to acknowledge all the people in Resolve, in particular Jeffrey Rabi, Hongmei Yang, and Michael McDermott, that has helped with the statistics. Thank you.
Do we have any questions? So I have a question. You know, if we look at rare disease broadly, we know the average time to diagnosis is somewhere in the order of 7 years. There's often several misdiagnoses on the way. So, you know, in your clinical experience, you know, if the age of onset is described as over age 45, there's no facial weakness. I mean, are these patients often misdiagnosed, or are they just undiagnosed until they receive their FSHD diagnosis?
So in my experience, they frequently come for pain or for lower limb involvement or for actual weakness. And so then when you ask them how long they have the pain, it's, I mean, they minimizing the symptoms. So they are saying maybe 1 year, 2 years. So for this reason, I think the diagnostic delay is not so long, because they are maybe underestimating the symptoms. Or you see this patient when you are doing a familiar search for FSHD, and you see the grandmother or the grandfather, more than grandmother, having this phenotype. So you do the diagnosis, and the patient is considering himself as asymptomatic or poorly symptomatic. For this reason, I think there is a...
Okay.
Hi Sabrina, thanks. Also in our cohort, we observe similar data. One question, have you data about the genotype-phenotype correlation in this group of patients?
Yes, I have data. Most of these patients are in the higher part of the repeat number, between 7 to 10. There is an increased number of later onset, but then it's, I mean, I didn't find any clue for the moment to predict if this patient will be more asymptomatic or they will be more affected, like the one that I showed in the beginning. So, but they are in the higher range of the repeat size.
Any other Questions? Oh, we have one.
I'm a little surprised at the mean age of onset. Were you at all, that's a fairly large study, were you at all surprised at the outcome?
Sorry?
Were you at all surprised at your result? Is that mean age of onset characteristic of France, or is it, does it correlate to other countries?
This is a patient-reported age at onset. It's not the real age at onset, because when you ask the patient what age they start to have the problem, they will tell you the age that they start feeling the problem. But we have a lot of patients in the French cohort. We have a lot of patients with higher age, because I collect a lot of patients in the south of France, so in which all the people are retiring. Maybe this is a bias in the FSHD database, French database. But I'm diagnosing a lot of patients later in life.
So I was misinformed before seeing this data. I was surprised to see that your mean is as high as it was.
Yeah, you can have diagnosis at all ages for FSHD, and you can have later onset, especially for people with a higher number of repeat.
Okay, any other questions? So thank you.
Thank you.
So we are going to take a coffee break, and we're going to restart at 3:50. So that's in 25 minutes.